from all of us. So in a change of title from that advertised, Chris Thompson is going to talk about the diagnosis and management of SIADH. Professor Thompson graduated from Dundee University a couple of years ago, he tells me, and he's travelled around the world. The bit I missed out from my splurb on the email is that he spent some time in San Francisco on a fellowship. He's just shared with me a couple of pubs to go to when I go there to a conference later in the year, which was very helpful. And he returned here as a senior registrar. I understand some of our current consultant body actually worked for him as a house officer back then, and they seem to have, he's moved on, they haven't, but everything comes full circle, and he's returned here to talk to us about the diagnosis and management of SIADH. He was part of the team that came up with the new guidelines for hyponatremia across America and Ireland, and he's going to tell us about hyponatremia in the next 45 minutes. Chris. Brief round of applause for Professor Thompson. Very good.
It's great to get a round of applause before I speak. I rarely get one after. So thank you very much for the introduction. Delighted to be back here. Lots of changes in Dundee since I was a student. In those days, doctors wore ties. But also, the MC Bar, which is down in the Ian Lowe Centre, used to serve beer at half-time. At lunchtime, so you could actually get with your lunch a half pint of heavy, and I used to work behind the bar in the evenings at all the do. So that's a sort of deterioration in standards, I think. The other thing that we could do in those days, you could do medicine by correspondence course. And myself and my university flatmate, Dr. David Johnson, one of your gastroenterologists, actually completed medicine through correspondence course, spending most of our time on attachment in Menny's Bar on the Perth Road. It didn't seem to do any of us any harm. So, what do I do now? How do I get...
Sorry.
Where's my...
Okay.
We don't have technology in Ireland, so I don't know what to do here.
Yes.
There we go.
There we go. Sorry about that.
Great. So, I'm going to talk mainly about SIADH, but putting this in the context of the broad issue of hyponatremia. I'm just going to share with you some of the recent changes in management that are recommended by the new guidelines and illustrate some of the controversy between the different guidelines that have been produced. This is going to be a clinical talk by and large. I'm going to try and keep it as patient-orientated as possible, and although there's time at the end for questions, if somebody wants to interrupt me with a burning issue or a violent disagreement, I'd be delighted to do that. This is just a few of my disclosures. So what I'm going to talk about is the background and diagnosis of SIADH, the management, and new thoughts on emergency treatment for those of you involved, like I still am, with acute general medicine. So this first thing to say, this is the commonest electrolyte abnormality that any of you are going to see in practice, and this doesn't matter whether you're in endocrinology or renal medicine or any other specialty. So a significant number of patients are going to have hyponatremia, and of those, a significant minority are going to have levels which you might expect might be clinically significant. But this is going to affect the respiratory physicians, the ITU physicians, it's going to affect the cardiologists with their heart failure patients, the hepatologists with their liver failure patients. Because of our situation in Dublin, working in a hospital which is the National Neurosurgery Unit, we've also shown ourselves that it occurs in significant numbers of traumatic brain injury patients, significant numbers of subarachnoid hemorrhage patients, and significant number of patients who've had pituitary surgery. And we live in an ageing population, so in all of these subgroups, dysnatremias, hypo or hyponatremia, are commoner as you get older. And we're going to see more of it as a result. So we all know that if you've got really bad hyponatremia, it can be a nasty thing to have. This is a set of statistics looking at the traditional view of symptoms and mortality with hyponatremia produced by Jeff Gill in Liverpool some time ago now, nearly 10 years ago, showing that as the plasma sodium drops, there's a progressive recruitment of neurological conditions ranging from mild symptoms right the way through stupor, and once you get to less than 15, a 50% chance of actually going home in a box from hospital rather than in your relative's car. And interestingly, he didn't even look at patients who had sodium levels above 125, though in fact every study that has looked at this population, 125 to 135, also show increased mortality compared with unatremic patients. But I think we probably all know that this is a slightly simplistic view of hyponatremia, because it's not so much the absolute level of sodium that counts, it's how fast it develops. These are two patients that you may recognise yourself from your own practice. This is Mrs. Kelly from up in Lochee, 80-year-old lady. She's on a big dose of bendofluozide. She's got a sodium of 118, but she's had that for a number of years, and she really only gets symptoms if she stands up quickly when she's at Mass, and she's been kneeling down, she stands up, she gets postural hypotension because she's a wee bit volume deplete. On the other hand, this is a guy that I look after, a 32-year-old man whose sodium fell after he'd had evacuation of a subdural hematoma. It fell from 142 to 125 very rapidly over 2 days, and this guy has got acute cerebral edema, and he's got significant problems as a result of that. These are two different situations here. This one is something that shouldn't be tackled aggressively, and this one that absolutely should, and we'll address that as the talk goes on. And this is some old data which is still valid today. This is Alan Arieff's group in the Vets Hospital in San Francisco, looking at what the likely complications of acute versus chronic hyponatremia. Acute less than 12, chronic more than 3 days. Slight difference in the plasma sodium averages, but they're both severe hyponatremia. But look at this, acute hyponatremia, 100% of them were stuporosed, significant number had seizures, 50% of them died, 36 of them died due to the hyponatremia, whereas the chronic hyponatremia, a little less of a blue flashing light situation, something that doesn't have to be tackled head on acutely because there's downsides to doing that. So does it matter? When I was an intern or an SHO or even a senior registrar in Nine Wells, we probably didn't think that it didn't, but every single study, every one, of any form of hyponatremia shows that hyponatremic patients have increased morbidity, mortality, duration of hospital stay, right across the board, whether it's in hospital or in the community. We know that as the sodium drops, there's an increased rate of gait disturbances and falls, and as this is a disease or an abnormality that we see in the elderly population, this becomes significant, particularly as people with hyponatremia who fall are more likely to get a fracture than people who are unatremic can fall. And there's good data now from both animal evidence and human evidence that hyponatremia actually starts leaking structure out of the bones and causes osteoporosis. This is a patient of mine with a fracture after a fall with hyponatremia. But these are statistics applicable to hyponatremia. And I think what I'm going to try and tease out over the next few minutes is the difference between hyponatremia due to SIADH, which is what I want to talk about, and other hyponatremia, because it is very important to regard hyponatremia as accurate a diagnosis as anemia is. You don't...
Sorry, can I just cut in a second? Yeah. I think Perth have dialed in and they don't have their mic muted, so they're coughing and spluttering over you. Perth, if you can hear me, can you turn your mic off? Because we can hear you. That may have done it. No? Yeah, I have that effect, yeah.
Sure.
Okay.
Is it bothering anybody? We plough on. This is data that is in progress with my current research fellow who's looked at a large number of patients prospectively with hyponatremia and divided them up into patients who have hypovolemic hyponatremia due to diuretics, gastroenteritis, etc., hypovolemic hyponatremia, which is liver failure, CCF, etc., and SIADH. And you can see that there's very significantly less of mortality with SIADH compared with the other two forms of hyponatremia. And this is quite important when you look at the data for hyponatremia. It is an all-encompassing set of data. Most of it, it's mostly retrospective. It doesn't differentiate between these different types of hypovolemia, and I am going to be concentrating on SIADH. So should we treat it? This is probably the most important question, but there is data showing that if you look at patients with thiazide-induced hyponatremia, you get complete resolution of symptoms with reversal of the hyponatremia. The SALT-1 and SALT-2 studies showed improvement in well-being and quality of life scores with normalization of sodium. There's data showing improvement in gait. And this was quite interesting. This is a way of measuring gait where you have somebody on a treadmill which measures deviation from the norm. So this is somebody with a sodium of 124, and this deviation we would all have straight lines like this, and when the patient was corrected, almost a straight line like this. And this was data produced by Greenberg and colleagues in a series of a number of patients with really quite moderate hyponatremia, showing an improvement in gait with restoration of eunatremia. And there's some retrospective data that if you compare patients who are treated for hyponatremia while they're in hospital, as opposed to those for whom hyponatremia is ignored and left alone, there's a higher mortality, 3 times higher, in the patients who are untreated for hyponatremia. In our own audit, this is a medical student audit last summer, looking at plasma sodium less than 120 and 129, small numbers because it was a student project, it was retrospective, but look at this, lower mortality in the group who had the very low sodium. This is just a comment, this is not a trial, this is not prospective, but if you look at this, 90% of the patients who came in with a sodium less than 120 had an endocrine or a renal consultation, and 90% of them were active managed, compared with much lower rates of referral in the patients with moderate hyponatremia, but who had almost twice the mortality. So we're looking prospectively at this now. This was a nice little bit of grant priming data that we could put in, looking for money to look at the prospective trial, but looking as if the ones who are referred and managed, even though they have more serious hyponatremia, have a lower mortality than the ones who perhaps are relatively neglected. So, SIADH diagnosis. I think it's important just to emphasise that hyponatremia does not automatically equate to SIADH, and in fact the wrong diagnosis can lead to treatment which is not only incorrect but can be injurious. And this is a patient from when I was here as senior registrar.
Hello, welcome to the Janet video conferencing service. Please enter the conference code now.
I've no idea.
Okay. So this was a patient on 5 and 6, which was the GI ward at the time, and I was asked to see a patient who was admitted with upper abdominal pain and vomiting. He was a boozer. His blood pressure was okay by the looks of it. Sodium was low, and the SHO on call, SHOs in those days made decisions, and they remembered something vaguely that if the urine osmolality was higher than the plasma osmolality, this was SIADH. So they treated with SIADH with fluid restriction. Now, is anybody here uncomfortable with this scenario so far? Is everyone comfortable? Is anybody awake? Okay. Well, I think there's 2 things to think about. If you've got SIADH and you've got enough excess water in the system to get your sodium down to 121, that urea is too high. And secondly, whenever you see this symptom here, vomiting, you've got to really convince yourself that the patient is not going to be hypovolemic. And in fact, when we got asked to see, they came to see us and they said, look, we've done that fluid restriction thing you tell us to do, but they've got worse. The urea had gone up, sodium had gone down. By this time they'd done a urine sodium, and it showed that there was secondary hyperaldosteronism, avidly retaining urine sodium. This is incompatible with SIADH. Blood pressure dropped to the guy's boots when we stood him up. This guy had hypovolemic hyponatremia. Not only was the treatment that was given not likely to improve the patient, it had specifically made him worse, because a guy who was hypovolemic was actually fluid restricted. And of course the correct treatment for this guy was intravenous saline to replace what was missing. And in fact what he had was the upper GI ravages of alcohol. He had esophagitis, gastritis, duodenitis, and diagnosing this guy's SIADH was the wrong thing to do. This is Kevin, who presented to me a couple of years ago. Now, Irish people are not supposed to look like this in Tenerife in summer, but in the middle of winter, we're definitely, we've got pasty skin and freckles and blue eyes, but this guy just looked a wee bit different even walking in. This is him in the middle of the winter, and my SHO, who's doing membership, phoned up and said, "Boss, I've been asked to see this patient. They say it's SIADH, but it looks to me like classical Addison's disease." And we would expect our SHOs who are doing membership to look at this set of electrolytes, low sodium, high potassium, evidence there with a raised urea, normal creatinine, volume depletion, high urine sodium, low blood pressure, low glucose. We'd expect them to look at that and just make a clinical diagnosis. But again, fluid restriction, if it had been implemented, would have been the wrong thing, simply because they're hypovolemic, but it also would have ignored the fact that the patient needs steroids, fluids, glucose, etc. And again, if we get back to Mrs. Kelly from Lochee that we talked about previously, with the low sodium, hypokalemia due to thiazides, she's got volume depletion with a raised urea and a raised creatinine, she's got a little bit of hypoglycemia because she's on a thiazide diuretic, and a postural drop. If you look at these three patients, you can see these are not SIADH. Okay? So the clinical assessment, there's a number of algorithms that you can put into place, and the one that I recommend to the junior staff, because it's simple to understand and it gets most things right, is to divide the patient on the basis of the volume status into hypovolemia, euvolemia, hypovolemia, and then look at the urine sodium as well. Urine osmolality is more or less unhelpful in most cases. But you can see this is the stuff we're always good at. Once you're an intern, you recognise this. Ascites, high JVP, edema, we're good at this. It is sometimes difficult to make the clinical... Can we not just shoot the guy? You're looking at... this is sometimes a little bit more difficult, but, algorithms are guidelines.
Please enter the conference code now.
Following this guideline will not make you an expert overnight. No algorithm does that. You still need experience, you need acumen, and you need a clinical view of the patient. That comes from experience and from being on call at night and doing your overtime like everything else. You can't get really expert at this any more than anything else unless you put the time in. So the diagnostic criteria for SIADH, if you're going to diagnose this, by definition, obviously, your osmolality needs to be low. Urine osmolality is a bioassay.
First participants to join the conference.
We've been here a while, mate. It's a bioassay for the action of vasopressin. So any urine osmolality greater than 100 is telling you that you have got circulating vasopressin acting at the kidney, which in the context of hyponatremia is inappropriate. So you don't need to have a urine osmolality greater than plasma osmolality. If you got one of those old textbooks, throw it in the bin, anything over 100. Patient must be euvolemic, okay, clinically euvolemic. And the key thing that you do have to do is look for urinary sodium excretion. It should be elevated in SIADH. If you've got a low one, it really indicates volume depletion. And you have to exclude particularly adrenalism. These things I think you should just ignore. So, the correct diagnosis of the underlying cause of hyponatremia determines whether the correct treatment is prescribed. We've seen that from the three people that we've already looked at. And that's because the treatment is etiology dependent. Hypovolemia is going to be IV saline plus the treatment of the underlying cause, steroids for Addison's. Hypovolemic, that's easy, diuretics and the underlying cause. And what we're going to concentrate now is euvolemic hyponatremia. So, let's get it back to the patients. That's what we hear about. This is an old fella who was sent to A&E in Dublin, confused, unsteady in his feet, headaches. The doctor said, I think he's had a change in personality. I think he's got a brain tumour. Would you do a CT? That came back normal. They then did some electrolytes and significant hyponatremia. Looked pretty typical of SIADH. The blood urea was low. The patient was euvolemic, raised osmolality, raised urine sodium, fairly classical, and the X-ray showed a left basal pneumonia. So this looked like a fairly typical thing that you all see on take nights. 10% of patients with pneumonia develop SIADH, and normally it gets better. Fluid restrict the patient, sodium gets better as the patient gets better. But in this case, the patient got better from the pneumonia, but the sodium stayed low. So we revisited the diagnosis. So, any further diagnostic tests that anybody wants at this stage? So it's SIADH. We thought it was pneumonia. Didn't it get better? Anything else? Does the patient need management? Any thoughts? And what treatment should be given? Okay, these are the conundrums we had. So the further diagnostic tests we had, TSH was normal, synaxin test was normal, so no endocrine problems. CT abnormal, abdomen was normal. CT thorax showed bronchiectasis. Wasn't shown up on chest x-ray, but he actually had quite bad bronchiectasis. This is why he got the pneumonia, and this is why he also had hyponatremia. Bronchoscopy was normal, he didn't have a cancer. SIADH secondary to bronchiectasis, and the problem with this is he is now going to have hyponatremia for the rest of his life. Now, during the hospital, we got his sodium up to about 130, and he said, God, I feel better, I can walk now, I can think now, I can read the paper I feel much, much better. What are we going to do when we go home? And that's the situation that we need to discuss now. So what are the management options for chronic SIADH? This guy's going to be symptomatic for the rest of his life with no treatment, so we have to do something. So here are the possibilities that we're going to go through here. Fluid restriction, hypertonic saline, urea, dimethyl-cycline, tolvaptan, and loop diuretics with replacement of oral sodium alongside it. So, the guidelines from both Europe and from America say the same thing. First line, in this circumstance, should be fluid restriction. Okay? It's probably what you all do. I'm going to ask you to put your hands up here. Here's the European things. In moderate or profound hyponatremia, we suggest restricting fluid as first-line treatment for SIADH. The American guidelines, exactly the same. Fluid restriction, but consider pharmacological therapy under select circumstance. So, if in your practice you're using fluid restriction, you certainly have the backing of the guidelines. So, who here would use fluid restriction as first line in this patient with chronic hyponatremia? Put up your hands. Okay, so about 10% of you. And who would use something else? Okay, so 90% of patients in Tayside are working for doctors who are going to ignore this, and 10% are going to use fluid restriction as first-line treatment as per the guidelines. So I agree with you, but I don't know what's happening here. This is the single randomized controlled trial of the use of fluid restriction in hyponatremia published in the literature. And it's patients with chronic hyponatremic encephalopathy, and I'll just show you the 14 patients here who were treated with fluid restriction. 10 died within 1 day, 1 died at 70 days, and 3 people were permanently institutionalized. That's the evidence base upon which the 10% of you who are going to trouble yourselves to treat this patient are basing it on. Now, I'd probably do the same, but the evidence base is a little bit sticky. Is it likely to be effective? So could I just, those fellas who put their hands up now, put them up again, the people who went for fluid restriction? There's even less of you now. Keep your hands up if you think that the fluid restriction is going to work long time. Is that one? There's one optimist. So basically, of 90% of you are not going to treat this guy at all. You're going to let him fall over, you're going to let him come in with recurrent admissions, you're going to ignore him. That's pretty much what happens in general practice. 10% of you are going to use the first-line treatment, which has absolutely no evidence to back it up, and none of you think it's going to work. Is that... Graham, you stuck your hands up. Is that's reasonable? Okay. So, there are some predictors, mind, of whether fluid restriction is going to work. And these are quite useful in clinical practice. And I think one of the reasons that you might do a urine osmolality measurement when you find somebody with SIADH is not particularly diagnostically, it's not that helpful, but is because if it's more than 500, you know that fluid restriction is a waste of time. You cannot restrict fluid enough to reverse hyponatremia if the urine osmolality is more than 500. If you can get it, we've started looking at this for research purposes, if the addition of the urine sodium plus the urine potassium is more than the urine sodium, that also predicts failure. If the urine volume, if you can ever get a nurse to measure it, is less than 1,500, that predicts failure. And if the first increase in the first 24 to 48 hours is less than 2, it's not going to work either. So this is a bunch of useful things to take away with you in terms of predicting response to fluid restriction. And in fact, in a prospective study that we're doing now, and we're just analysing the data, in a significant number of patients, about 40% of patients with SIADH have a urine osmolality greater than 500, 22% have a urine sodium and potassium greater than plasma sodium, and 40% have a urine volume down at that level. And in fact, half the patients with SIADH, you can predict from before you start treatment, then they're not going to respond to this treatment, that 10% of you pick as first line with no evidence base and no expectation that it's going to work. So, in a sense, if you are going to treat it, fluid restriction might have the backing of the guidelines, but it might not do much. Whereas we now have a treatment that's available, I'm not sure if it is in Scotland, but it's available, the European licence, Vaptan, which is a vasopressin 2 receptor antagonist. This is the SALT-1 and the SALT-2 studies, one conducted in America, one in Europe, same protocol, looking at patients given Vaptan or placebo for a combination of euvolemic and hypovolemic hyponatremia, and a very significant improvement in sodium in the Vaptan group compared with placebo. And this was not just the SIADH getting better, because at the end of the study, when the Vaptan was stopped, bang, straight down to previously. And this is the only agent now that's available which has randomized, placebo-controlled prospective trials which back up its use in reversing hyponatremia in SIADH. So, the European guidelines say under no circumstance would they recommend Vaptans. And partly that was because the European guidelines were top-heavy with Belgian urologists who use urea, which again has no, it doesn't even have a preparation, never mind an indication for use in hyponatremia, as treatment for hyponatremia. And they have sort of specifically recommended the use of urea, which if you order it in Ireland, because I did, to try and get our pharmacy to make it up, because it was cheap, it comes in a big sack saying, not fit for human consumption. Because it actually tastes like you would expect it to taste. Now, anybody who has drunk Belgian beer might not be surprised that the Belgian population seem impervious to the taste of urea, but there you go. But they say there's no proven outcome benefit aside from increase in serum sodium concentrations. I think that's the job of the drug. And most prominent safety-related factor is the increased risk for overly rapid correction of hyponatremia, but it's no more than any of the other treatments that are given. So, we'll skip this because I've got my view of the US and the guidelines is the European guidelines have a double standard for evaluating and scoring the treatments they recommend. In other words, they recommend 3% sodium bolus, urea, loop diuretics, which have no evidence based, versus those they don't, which do have an evidence base, and I don't think they've got any supporting evidence in their favour. Whereas the Irish and US recommendations recommended that after fluid restriction you can use any of these things depending on what the patient needs at the time, and that we certainly didn't say that you couldn't use any of these other things, urea, loop diuretics, etc. This was debated at the ECE, the European Congress of Endocrinology, in Dublin 2015, and as a bit of a surprise for the European people, in fact, the majority of people voted for the US guidelines and this is the evidence here for you. Most people suggested they preferred the ability to use Vaptans as recommended by the American guidelines. So, what are the management options? We've got fluid restriction, which is free. Brilliant. Our own data suggests that you will get, over the course of a hospital admission, a 2 millimole increase in plasma sodium over and above the patients who, in our hospital, like everybody at the hospital, people ignore. So it doesn't really work. Therefore, it's not reliable, evidence-based, nothing there, and no side effects. Demeclocycline is relatively cheap. It can work, but it's not reliable, no evidence data, and we don't use it anymore because of hepatotoxicity, nephrotoxicity, photosensitive rashes. Urea is cheap, it does work, It is reliable. It doesn't have an evidence base. Very few side effects. The problem is there is no license for it. There's no preparation for it. And you have to get your pharmacist to agree to buy in this sack that says not fit for human consumption and make up the bags for you. Our pharmacists wouldn't do it when they saw the not fit bit. I should have taken that to use as a slide. A lot of my renal colleagues recommend this, again with no evidence base, but the combination of furosemide to produce a natriuresis and an aquaresis, and then replace the natriuresis with oral salt, is apparently useful, but I have no experience. Vaptans, very efficacious, very reliable, significant evidence base, but significant cost. And this is the massive problem with the Vaptans. It's about €120 a tablet. So this is really, this is oncology expensive. This is not the sort of thing as an endocrinologist I'm used to prescribing. And that's the main problem with it. So do I use Vaptans? I do, within safe clinical limitations, with an appreciation of the economics. And because I know that they aren't used widely in Scotland, I'll just go through some of the scenarios in which I've found it to be useful. This fella here is one of my 3 patients who are on chronic tolvaptan because his hyponatremia is going to be there for the rest of his life. With a single tablet, half tablet a day, his sodium is up to normal. When we've got him onto maintenance now every 3rd day. Plasma sodium's great, no gait problems. He's independent, and he's delighted because he can fill in his own boogie slip now, and he can do that without having to ask somebody to put a line on for him. He's thrilled with himself. He's got his life back. Next guy is a classical case for our consult service with the neurosurgeons. Guy who came in with headache, collapse, meningism, hypertension, diminished consciousness, evidence of blood in his brain, and an anterior communicating artery aneurysm, which they clipped, and everything's going fine. But 2 or 3 days afterwards, his GCS started to go down, had poor rehab, wasn't engaging with the physios, and they did a sodium, and it was right down in his boots. Look, very typical for SIADH. So they called us and they say, look, this guy isn't doing very well. We don't know whether we have to go into his head now to see if there's a leak that we didn't cure with the clipping, or whether it's his sodium. Can you sort this out for us? We said, not a bother. Urine osmolality was 800, so he wasn't going to respond to fluid restriction. It was a waste of time. Random cortisol was high, as you'd expect from a stressed individual. Our own data shows 10% of people who have subarachnoid hemorrhage have acute ACTH deficiency. And he was on IV fluids, and he wasn't doing well. So neurosurgeons won't let you fluid restrict anybody. They're afraid of vasoconstriction. So we gave him tolvaptan. The sodium over the next 48 hours came up gradually from 124 to 136. The patient woke up, engaged with the physios, and we gave the patient tolvaptan over the next week or 10 days, during which time the SIADH resolved as it always does after subarachnoid hemorrhage. But we were able to answer a clinical question, we were able to prevent unnecessary surgery, and we were able to get this guy to engage with the physios until the thing sorted itself out itself, earlier discharge from hospital. This old fella is a guy who had been investigated in the past, chronic stable hyponatremia, no treatment, admitted for a TURP with a plasma sodium of 122. The anaesthetist came and saw him and said, correctly, he's not fit for operation. You're going to fill him up with fluids. If you do that to him, he's going to drop his sodium, he's going to have a fit. We're not operating, we're not anaesthetising him. What was wrong was they said discharge and water restriction and readmit for surgery in 2 months. So this bit is sensible medicine, this bit is what's called passing the buck. Because when they called us, his urine osmolality was 750, he wasn't going to respond to fluid restriction. We started tolvaptan, we said don't discharge him, we'll sort this out. Tolvaptan, sodium went up over 2 days. We kept it going during the surgery because it meant they could fill him up with as much fluid as they want and it would just go straight through him. And plasma sodium remained perioperatively up, and he went back off tolvaptan to his previous stable hyponatremia. So we allowed this man to have his operation. Third is a retired colleague who had a non-Hodgkin's lymphoma with chronic SIADH. She wasn't having any treatment. Interestingly, the specialty with the highest rate of hyponatremia is oncology. The specialty with the lowest rate of referral to endocrinology is oncology. And whether they think that because they're doing muscular things with chemotherapy and radiotherapy, that trivial things that hyponatremia don't matter, I don't know, but very rarely refer. But they referred this girl because previously when she'd had chemo, her sodium had dropped to 112, she'd been obtunded, and she'd spent 2 weeks in hospital after her chemotherapy, and they didn't want to do this again. So they said, can you help out? You know the script by now. We said, we can. Vaptans 30 milligrams a day, rose over 3 days, she got her chemo, she was fine, sodium stayed normal. She now funds her own Vaptan because she can do the cryptic crossword in the Irish Times again for the first time in 2 years since she had SIADH, and she thinks it's worth it for her quality of life. So that's a sort of spectrum of the sort of things that situations that we use Tolvaptan for. So the practical issues, it's licensed at 15 milligrams and 30 milligrams. Many clinicians are now using half doses, and often half doses every second day, so that quarters your economic costs. Care should be exercised. I don't tend to use it if it's very severe hyponatremia because the original data did not look at these people, and the suggestions from anecdotal evidence is that the more rapid reversal of hyponatremia occurs in the patients who have the lowest sodium. So we still go very carefully in them with low-dose intravenous saline. Very useful short-term effects, too expensive to use for long-term effects. And until another drug comes on the market to challenge it economically, I think it's going to be out with the realms of chronic treatment for most patients, which is a pity because it is without doubt the best treatment for chronic hyponatremia that there is. So just finally, 48-year-old man brought into A&E with confusion, sodium of 113, urine osmolality up, looked like SIADH, 2 seizures, didn't regain consciousness. Is this a medical emergency? And the answer is yes, because in this circumstance, the death rate without treatment is around about 80%. So this puts into perspective crushing central chest pain going to the left arm, for which there's an entire unit in every hospital to manage and has an inpatient mortality of about 10%. This is about 80%. And this comes in to all of us on our take nights. This is the problem. This is somebody who obviously had a bad outcome, but this is a brain of somebody with cerebral edema, and when the sodium drops fast, there is a low osmolality in the plasma, high osmolality in the brain. The brain sucks fluid in, therefore, because of the osmotic gradient, the brain expands and you get cerebral edema. That's why this guy was fitting, that's why he was stuporosed, and that's why this is a medical emergency. So, sorry, I don't know why. Option 1 is to do nothing, and that's what happens here. Option 2 is to treat this aggressively with acute elevation of plasma sodium, which is associated with the reduction of both mortality and long-term neurological damage, but has a risk that we're always worried about of osmotic demyelination. This is the central pontine myelinosis in this area here. And worrying about this often paralyzes us from acting and therefore leading to this sort of thing. So this is the scenario that I just want to finish about, severe hyponatremia, because there's been a change in the recommendations. So for years I have given a continuous infusion of 3% saline, looking not to increase the plasma sodium by more than 12 millimoles per litre over 24 hours as a constant infusion. Things have changed. So the recommendation now and the guidelines are slightly different. It is thought that the key thing in that acute cerebral edema is an immediate rise in plasma sodium in the first 4 hours of around to 4 to 6 millimoles per litre. To raise plasma osmolality, suck some of the fluid back out, and there is some anecdotal but not prospective evidence that this will reduce the acute death from cerebral edema. So the recommendations now are to give boluses of 100 ml IV 3% sodium and chloride over about 10 minutes and up to 3 as needed to obtain a rise in plasma sodium of 4 to 6 millimoles per litre. That can be enough, even when it's down at 112, to save the patient's life. Okay, in the acute sense. And then over the rest of the 24 hours, you still infuse at a low rate with the similar 24-hour targets. So for a standard patient coming in, you're looking for a maximum rise of around 12 millimoles per litre. In fact, the target rise should be about 8. That's all that you need. There's a difference between the target and the maximum, because anyone in acute medicine knows this is actually quite a difficult science here. It's sometimes difficult not to overshoot. So there's a difference between the target and the maximum. And if you have a high-risk patient, if it's one of Dave Johnson's patients from the liver unit, who's an alcoholic, who's malnourished, etc., you have a slightly lower target and a lower maximum because they're more vulnerable to central pontine myelinosis. So the patients at high risk you have to worry about, the serum sodium's right down in the boots, hypokalemia, alcoholism, malnutrition, advanced liver disease. If you've got people with these sort of syndromes here, you go easy. Slightly less of a 24-hour maximum. And in fact, when we looked at my analysis of the guys that I treated over the last few years, 48 over the last 15 years that we've treated aggressively with hypertonic saline, people with levels of sodium down at this sort of range with signs of cerebral irritation, pretty low mortality. We didn't have anybody with osmotic demyelination. We didn't exceed the rate of rise. But when we looked at the 4 deaths they had, they were all guys who died early in the first few hours, and there had been a negligible rise in sodium in those guys. And so the tantalising thing that I think about when I look at my own practice is, if I'd used the new guidelines, would it have made a difference to these 4 guys? I don't know. It's retrospective stuff. But we have changed now, and we're monitoring our performance in terms of safely elevating the plasma sodium. But the tantalising thing is the new changes could save lives in this really high mortality situation. Whirlwind tour of hyponatremia. Thanks for staying awake.